appreciate folks being on board, and look forward to presenting to you. And just to remind folks who, I know some of you know me, some of you don't, but I spent 20 years up on the North Shore at the hospital in Skokie, at the former Rush North Shore, and maintained my practice. I came back to the university in 2012 because I found that I was able to do things, but I couldn't teach. I couldn't pass things on, and so I kind of felt, boy, I'm gonna not be around at some point. Nobody's gonna know how to do certain things. So I really felt the need to get back to the university. And as it stands, I turned out to be the last man standing when the last chairman left. So I've been in the role of acting chair since then. It's a delight to address you. I know the NAMI Cook County North Shore chapter group very well, and it's always been a delight for me to be able to address the group, as well as use your resources for referring patients and their families to. And I really do make a very strong point of it, especially families, for family education and such, because my experience, your chapter in particular offers tremendous benefit and resources to families who are sort of at sea and overwhelmed with their circumstance. So again, it's a pleasure to be able to address you folks today. Medicines for serious mental illness, what are they and their effects? So serious mental illness, how do we define that? It generally is something that implies chronicity, mostly thought disorders. Certainly bipolar disorders fit within the criteria, but we're talking about the kinds of illnesses that become really disabling, and psychosis, whether it's part of a schizophrenic disorder, primary thought disorder, or part of a mood disorder that becomes more chronic in nature, it's very significant. So the disorders that may manifest with psychosis, it's a basic tenet of schizophrenia and schizoaffective disorders, but we certainly see psychosis occurring in mania, as well as certain depressive conditions, dementia as well, secondary to other medical conditions, autoimmune conditions and such, the neuropsychiatric disorders that affect people that could have a autoimmune sort of etiology, could be a toxic etiology such as intoxication with certain drugs, could be, or heavy metals and other such things. There could be an infectious component and such. And so it's important to sort of look at medical causes as well. But psychotic symptoms, when they occur, generally require treatment. And when they're in the part of a psychiatric disturbance, a chronic mental illness, becomes difficult to treat sometimes. The development and treatments for psychotic disorders really began in the 50s and the 60s and through this day. ECT, electroconvulsive therapy, was first conceived of as a treatment for schizophrenia. And it's a very interesting story, and that I love to share with medical students and residents, because as they come and observe ECT, I ask the question, can you tell me how ECT, syphilis, and the Nobel Prize are all interconnected? They tend to have difficulty with that, and so the bold ones will start to guess at things. But the story is that the first psychiatrist who won the Nobel Prize for medicine, there have been two. The first was Julius Wagner-Jauregg, who won the Nobel Prize in 1927, I believe, for his treatment of neurosyphilis a decade earlier. Dr. Wagner-Jauregg gave people malaria. He inoculated patients in the hospital in Vienna who had neurosyphilis. General paresis was the name of the disorder of psychosis associated with neurosyphilis. He inoculated them with a malarial toxin, gave them a fever, it was called fever therapy, raised their body temperature for 3 to 4 weeks or so, however long it took, for the symptoms of syphilis to resolve, the neurosyphilis to resolve. The organism that caused the neurosyphilis would die off at higher body temperatures, right? So before there were ever antibiotics, Dr. Wagner-Jauregg was the first to effect cures for neurosyphilis. Of course, then the patient had malaria, he would have to treat the malaria. Back then it was with quinine, really for the rest of their lives in order to control fevers. For that, he won the Nobel Prize. It was the first time the prize was given for using one pathologic state to treat another. And that's the key, that's the linchpin. And then people were looking around for pathologic states that would treat other pathologic states. The Germans, Seckler, and then Ladislav Meduna, Budapest, made the observation that patients with epilepsy over time stopped having seizures, but then developed this sort of chronic psychosis. And back then, anything that was sort of chronic and psychotic, they would call schizophrenia. But they thought maybe there was something exclusive about these things, that maybe the development of schizophrenia cured the epilepsy. They couldn't figure out how to make people schizophrenic because they didn't quite understand the disorder and how it came about. And plus, they didn't have any treatments for schizophrenia at the time. And it was rather cruel and difficult disorder to wish upon an individual. So they thought about it, I guess, and decided, well, if there is something mutually exclusive, maybe they could use seizures in a controlled fashion to treat psychosis and schizophrenia. And then, so that's how they began to experiment with ways to induce seizures. Meduna was injecting camphor and its synthetic derivatives to induce seizures. It was difficult to control until the Italians, Lucio Bini and Ugo Cerletti. Bini was the young professor, young new assistant professor in the department at Rome, who had an engineering background. Cerletti was the chair, and they came up with the electrical device that was the first ECT device in 1938. ECT was performed over the next several decades without anesthesia until mid-late 50s, when anesthesia was introduced. It was called modified ECT. And they sort of went through really most disorders. I think this is where some of the stigma attached to ECT comes in, because they were just sort of giving it willy-nilly because they didn't have anything else. They didn't have any antidepressants until imipramine was introduced in the mid to late 50s. Although around the same time they were discovering that the anti-infectives in the tuberculosis asylums were turning TB patients in a bit manicky, running around spreading their fomites at the sanitarium. That's couldn't let them out because they still had active TB. But the anti-infectives had a monoamine oxidase inhibition mechanism that would cause some patients to cycle into mania. They were not depressed, certainly. Chlorpromazine was developed in France at one of the French pharmaceutical houses in the 50s, originally conceived of as an anesthetic agent. In fact, the North Shore had a surgeon who's passed away, and sadly, I can't remember his name. He was at Rush North Shore. We used to have lunch with him, and he told the story about, I think he grew up in Egypt, and he went to medical school in Paris, or did his resident, or I think Turkey, then did his medical did his first residency in surgery in Paris. Tells the story about being called down to the psychiatric hospital down the street with a gentleman who had a separated shoulder. And they had to go reset it. They didn't know what it was going to be like. He was a little bit agitated, and they had this new medicine that was being developed that would help people calm down, and they actually gave him a shot of chlorpromazine as a sedative so that they could reset his shoulder from the separation in the intake department at the psychiatric hospital down the street. And that was before it was even, I think, released. He actually stuck a few vials in his pocket when he came to the US to have, because it was really, you could do that stuff back then with these medications. And I think he tells a story about making rounds with the surgery team at a hospital. I think it was in Rockford or somewhere in the Midwest during his training here, and pulling out a vial of chlorpromazine and suggesting they use it in a similar case as a pre-anesthetic. Subsequent to the chlorpromazine, we really, the first generation antipsychotics, we developed the rest, high potency, low potency, different side effects and such. And it wasn't until clozapine was really brought about in the late 80s, 1980s, that we moved into the second generation. The introduction of clozapine was the first atypical antipsychotic. It really was very effective in reduction of positive and negative symptoms, really improved with patients who had or might be considered treatment resistant. I mean, it's a very effective medicine. It's hard to use, it's cumbersome because of the weekly blood tests, as you will know. It has side effects to deal with. I know we had some questions about managing the side effects of clozapine. It's good in that you don't see a lot of EPS, but you can see other sorts of side effects with hypersalivation, particularly at night, difficulty regulating body temperature sometime, appetite stimulation, all sorts of stuff. So it's not an easy medicine to use, but it is very effective. There have been refinements in the second generation antipsychotic, which is not just the dopamine blockade, but also some serotonin effects as well. And this is where we stand. The D2 receptor, the dopamine subtype 2 receptor, is the target for most of our first generation antipsychotics. Very effective against positive symptoms, high degree of extrapyramidal symptoms, the development of tardive dyskinesia and other side effects. Second generation comes about, it adds that 5-HT2A, which is a serotonin subtype receptor in the postsynaptic side, which some of the antidepressants actually either block or they will downregulate as part of their mechanism of action. And so it's incorporated into the drug, so they get both the dopamine antagonism or in some cases partial blocking. And then they get the serotonin effects, which really began to contribute to greater benefit for the negative symptoms of schizophrenia. The positive symptoms are the hallucinations, a lot of times affective instability, reactivity, high anger, reactivity, anxiety and such, as well as the really pronounced delusional thinking. The negative symptoms of schizophrenia relate more to sort of the sense of flatness or impoverishment, where they'll maybe lose emotional expression. They'll have often a blunted look or flattened look, and speech becomes monotone, and the negative symptoms really reflect some of the pathophysiologic changes that are occurring in the brain as a consequence of the illness. The nice thing about the second generations is that, again, they're useful for the negative symptoms. Different set of side effects that are problematic in and of itself. So you see a lot more metabolic issues. There are cardiac issues as well. Mellaril, an old first generation antipsychotic, thioridazine, was found to have a cardiac effect that really has been pulled from the market. And some of the second generation medicines also do that, where they prolong what's called the QTC interval, which refers to the repolarization. So when the heart sends the message to squish, move blood about the body, there is a period for the nerves to repolarize, get ready to fire again, to squish the next bit of blood out. And some of these medicines may slow down that time to repolarize to the point where there can be a disjunction between the node that sends the message out and the response of the heart fibers. And that can be dangerous. I apologize for some of the small print. That is actually not an up-to-date list. There have been the addition of Caplyta, which be honest with you, I have not gotten to know very well. I know most of the others quite well, not necessarily the Caplyta. Antipsychotics, second gens, are used. They're all approved for schizophrenia, psychosis and schizophrenia, several of whom are approved for use in mania and bipolar disorder as well. They're commonly used for mood stabilization. Some folks will use it for anxiety, sort of an off-label use. And some of the second generation antipsychotics actually have FDA-approved indications for depression, whether it's an adjunct to major depression or control of depression and bipolar disorder, another serious mental illness. The second generations actually go beyond dopamine and serotonin as well. It's been long thought that acute psychotic episodes are associated with sense of an inflammatory reaction going on in the central nervous system, or neuroinflammation it's called. And in states of active psychosis, there will be elevations of cytokines, which are inflammatory markers that one can find in the central nervous system and across the whole body. Interleukins, tissue necrosis factor are examples of these inflammatory cytokines. Folks have heard about the cytokine storm that occurs with COVID infection, where the virus induces the inflammatory response, and the inflammatory response is what attacks tissues in the respiratory tract and other organs. With COVID, that was the whole controversy with using hydrochloroquine, the Plaquenil, early on, with it, because it can have anything that can diminish inflammation may have benefit. Slow down these inflammatory cytokines with COVID. Whether there is a causal relationship with psychotic episodes, we don't know. It's just an associated finding, this neuroinflammatory state in active psychosis. These biomarkers are actually released by microglia, which are the support cells for the neurons, and they're rapidly activated by psychosis. And during these times of inflammation, it's the microglia and the inflammatory markers which mediate potential brain tissue injury during the psychotic state. I don't have it in this slide deck. I can show you, if anybody's interested, a representation diagram of this inflammatory cascade of events that can, and what it does in the CNS, if you'd like. Maybe after getting the chat, we can see about that. The nice thing about the second generation antipsychotics is that some of them actually, or most of them, have the ability to suppress the induction of some of these pro-inflammatory cytokines. It's not consistent between them all. Each one has little bits of different effects, but each of them seem to have this capacity to help diminish inflammation in the CNS. And the second generation's rapid inhibitory action on the pro-inflammatory cytokines may in fact be neuroprotective, meaning that it will help diminish the longitudinal effects of chronic inflammation in the central nervous system. And interestingly enough, haloperidol, the most commonly used first generation antipsychotic at this time, it's been noted not to have any effect on these pro-inflammatory cytokines. Clozapine has its neuroprotective effects by limiting production of free radicals, reactive oxygen sort of molecules. Aripiprazole inhibits glutamate-induced toxicity, increases brain-derived neurotrophic factors, and actually helps block other of these inflammatory cytokines. Same thing with olanzapine. Increases BDNF, increases mitosis, in other words, helps produce healthy neurons. They can reproduce, they can grow, and such. Haloperidol has a higher antioxidant effect than any of the others. Quetiapine inhibits tissue necrosis factor and nitric oxide, which is a oxidant, right? That increases free radicals, cell damage, inflammation, and such. Ziprasidone inhibits microglial activation. The microglia are what release a lot of these pro-inflammatory cytokines and such. And lurasidone, at least in small furry rodents, will increase brain-derived neurotrophic factor, which is required to help sustain the health of nerve cells. And that's what the slides I have. I could pull up the inflammation thing, but I think I see some questions and that I would love to answer. one question is, does Depakote help angry outbursts? Patient gives an example of somebody with active psychiatric illness and a history of traumatic brain injury, also on paliperidone and fluoxetine, benztropine and gabapentin. So angry outbursts. Angry outbursts can be the result of multiple conditions. It can be just a nervous system that has a vulnerability to it, where there's this sort of affective instability, where one hasn't necessarily learned how to sort of modulate their own emotions. A lot of adolescents will have angry outbursts because they haven't figured out how to do it. That's where the holes in the wall come in sometimes, as they experience frustration and such. But it occurs in adults and other conditions as well. Many years ago, when I was a young man in training, and Tegretol, carbamazepine, was the most highly prescribed medication in the prison system because it actually helped diminish angry outbursts, whether this is from, sort of neurocircuitry, misfiring, not necessarily epileptic in nature, but maybe, approaching a temporal lobe or behavioral sort of event. So does Depakote or divalproex, again, it's an anti-epileptic, and it should. It is not unreasonable to try it, based on history. Is there an FDA indication for divalproex or Depakote for intermittent explosiveness and such? No, I don't think there's anything that has an FDA indication for that sort of thing. But in terms of thinking in terms of it, of angry outbursts as an affective instability or inability to control or modulate one's own emotions, it makes sense that Depakote, divalproex, or any of the anti-epileptic drugs would have benefit for use. All right, I'm going to go back, see more questions. And the question about clozapine came in before tonight, and I think this addresses it. I'd like to know, what are the long-term side effects of being on clozapine? Long time, decades, right? If the patient can control their weight gain and have minimal other side effects and function at a high level, what are the overall physical risks is there, and can it be controlled? Clozapine in particular becomes one of those medicines where there is damned if you do and damned if you don't, right? It can help individuals who did not do well necessarily with the others, and yet with clozapine, they're able to live at home or live in the community, stay out of the hospital, have their symptoms controlled, function well. The long-term side effects, besides the important one, which is why we monitor the blood, of neutropenia, refers to the inability to produce new blood cell or white blood cells. So there are 5 different kinds of white blood cells. Neutrophils are the major one to fight, to fight infection and such. And when neutrophils get very low, one's ability to fight infection becomes vulnerable, becomes weakened. And clozapine and others, but clozapine more than the others, can diminish the bone marrow's production of this line of white blood cells. It is particularly prominent or more common. I mean, it's not common at all, but it would be more common in individuals of either Finland descent or Northern European Jewish descent, the Ashkenazi line. It seems to have a certain tissue type that makes it more vulnerable to this effect from clozapine, hence the monitoring. If that occurs, there are things that one can do. sometimes even giving lithium, which helps the body produce more white blood cells to counterbalance it if it's possible, it doesn't go too low. Weight gain is an issue. The metabolic syndrome is an issue where patients gain weight. They may gain more central weight, so body weight, abdominal weight, right, which is a risk factor to eventually developing diabetes. All of the atypical antipsychotics can affect the sensitivity of insulin receptors. So when you diminish the sensitivity of insulin receptors, body will produce more glucose, trying to overcome that lack of sensitivity to the insulin receptors. And you can counteract that. Sadly, we end up counteracting side effects with more medication. So one of the ways of doing that is with metformin or one of the other early diabetic medicines that can make insulin receptors more sensitive and help combat what the medication is doing. But to be perfectly honest with you, and I've seen patients do this if they're able to, the best way to combat weight gain, sluggishness, metabolic syndrome is actually through activity. So weight gain is about energy. It's holding on to energy in versus energy out. These medications will lower basal metabolic rate. Therefore, the amount of energy we use up in the course of a day is less if we don't change our eating habits to accommodate for that. If we take excess energy in, it goes into storage, right? It's a lot easier to put energy into storage than it is to get it out of storage. And so if one can be very disciplined and eat the right things and eat early and not go to bed, still absorbing energy, so eat 4 to 6 hours last before one goes to sleep, through a lot of increased activity, walking, whatever the exercise can be, one can control the sort of weight gain and the risk of developing a metabolic syndrome or diabetes in this fashion. It's really tough to do with the population, but I've actually had patients do it. One guy, he just started walking everywhere. And it got to the point where it was not only therapeutic exercise, he found it very soothing, but he lost a ton of weight and was in great shape for quite a while. So it is possible to combat it. It takes a lot of help, a lot of coaching to overcome the weight gain and the inertia that medicines can cause. Clozapine can be sedating, like some of the others. It's hard to get up and get moving. If one has the effect of sleeping 12 to 16 hours with medication, right? There are actually ways of combating that too. The sedation is it's kind of an antihistamine effect, and there are 2 medicines on the market that will counteract it. They're actually prohistaminergic in the part of the brain, the dorsal lateral prefrontal cortex, sort of our brain's central processing area, that it kind of wakes it up. And sometimes we have the pill at the bedside, set the alarm. If they can take it at 7 a.m., they'll be awake by 8, up and moving. So if there is excessive sleep, that can be counteracted as well. So the best thing that one can do to control the overall physical health risks of medication are going to be just lifestyle changes more than anything, and other medicines when needed. It's a question about the efficacy of ketamine for treatment-resistant depression. It's an excellent question. I know it's been very topical for a few years. The literature began with reports probably about 15 or more years ago about people going into the emergency department with profound suicidality and getting a shot of ketamine and kind of feeling better within a few hours, right? And it started to get looked at more closely. There was a group up in Duluth, Minnesota, I believe, that would bring patients to the office and give a ketamine IM injection, which is one of the ways one can administer it. And they would give a little Valium because sometimes you get a little it's a little creepy to start dissociating with ketamine. And they reported it. They had a series of cases and they reported it. And so it began to get some traction. Janssen Pharmaceutical, which was one of the makers of Ketolar, which was the branded ketamine, and they took the molecule and they sort of broke it in half into its two halves. There's R-ketamine, the right-handed side, and S-ketamine, the other enantiomer, the left-handed side. And they looked at it, the antidepressants of the S-ketamine, and they did it in a study. In fact, my very good friend and former partner in practice, Dr. Sajeka up in Skokie, has been working with these compounds throughout. He had several ketamine analogs, infusions in the office in Skokie studies, as well as the intranasal S-ketamine, which is the approved product now. It's called Spravato. The data is good. The data is good. What we see are a number of these ketamine infusion centers that have popped up. They're not run by psychiatrists. Most psychiatrists aren't interventionalists per se, and infusionists. And in fact, this is considered conscious sedation. And so whoever's doing it better have credentials to do it, and wherever they're doing the infusion better be, meet standards for conscious sedation. So you see a lot of anesthesiologists with these infusion centers and such. Problem with a lot of the ketamine infusion centers is that they use the doses that anesthesiologists are used to using. The dose that was described as being effective for depression was 1/2, 0.5 milligrams per kilogram. The anesthesia docs, for whether it's anesthesia or for pain treatments, some of the pain doctors will give ketamine infusions for certain chronic pain conditions. They'll use doses 2 to 3 up to 4 milligrams per kilogram, and they'll do an infusion over time. And you lie there and you spend a half a day at the ketamine clinic, and they charge a lot of money. And it probably isn't necessarily what one needs to treat the depressive disorder, right? So the S-ketamine has specific doses. We've seen it very useful. I know I serve as the physician for the S-ketamine clinic down at Rush University. Dr. Sajeka has a clinic in Skokie. I think there are other doctors that have been gotten approval as ketamine center. There's a central pharmacy. It's highly regulated. Certain things one has to do with the treatments to submit information as part of a risk mitigation program, a REMS program. So you want to go to somebody who does that. As ketamine is expensive as well because it's branded and such. Some people are using ketamine off-label and a nasal spray as well. So a ketamine infusion for depression is off-label. Not to say that it isn't helpful. Yes, ketamine nasal spray has on-label for use with an antidepressant as an adjunctive treatment in a major depressive episode or treatment-resistant depression. Ketamine, the nasal spray, also has an indication for use in the emergency department for suicidality, which how it was originally conceived of as well. But it's pretty much similar part of ketamine. Ketamine also works, and you can have the discussion with your doctors as to what the best route is if you want to pursue it. But we've seen some people who really don't do well, both with unipolar depression, which is the S-ketamine's indication. I've had some bipolar patients actually do really well with it. I mean, you have to keep an eye on it. It's not easy, but it can be useful. We have a question regarding second generations by monthly injection. So S-ketamine, I see a lot more questions coming on, so I'll be a little bit quicker with my answers for folks. Long-acting injections are the standard of care in Europe. They haven't met that level of use here. But to me, there's not just the second generation antipsychotics, which are expensive and sometimes difficult to get insurances to cover, but can be done. And they're very useful, and they're wonderful medicines. And sometimes the CNS penetrance of the injectables are better than the oral medicines, and so they have great utility. I still use fluphenazine decanoate. That's the old Prolixin decanoate. It's first generation. You don't get any of the second generation benefits, nor do you get any of the baggage that comes with the second generations in terms of metabolic functioning. And whereas a branded second generation injection cash might be $1,500, you can buy a 5 milliliter multi-use vial of fluphenazine decanoate or haloperidol decanoate for $160 retail, and that's 2 to 3 months worth of medication or more. So there are ways to go about either one, but second generation or long-acting monthly injections can be life-saving, and they've been shown to keep people out of the hospital better than oral medications, because it's just better compliance. As long as they can get the shot once a month, come in once a month, not have to worry about daily medicine. They're great drugs. You have the question about if Depakote was stopped 2 weeks ago, and today there was an angry outburst with police. Was it because the Depakote being stopped? Well, was it a consequence of going off the medicine directly, or was there just as a causal relationship, or just an association whereby going off the medicine, which was maybe preventing affective outbursts, all of a sudden, without the lid on top of the symptom, it shows up. So sometimes when you see things coming off medicines, it's not because the medicine going off caused it in any way as a withdrawal syndrome. It's just the uncovering of what lies beneath the medicine starts to become expressed again. That would be my answer to that. What are the short-term and long-term side effects of lurasidone, and how effective is it for bipolar 2, or to take with anti-anxiety or depression meds? So lurasidone is actually one of the cleaner mechanistically second-generation medicines we have. It has both that D2 antagonism of adequate potency. It has the 5-HT2A antagonism, blocks that postsynaptic serotonin receptor. And interestingly, it also blocks a second serotonin receptor called the 5-HT7 subtype receptor. That receptor has input into cognition, circadian rhythm regulation, and actually smooth muscle relaxation. So it might be a good medicine for irritable bowel. I don't know if it's ever been tried with that, but lurasidone is actually pretty clean medicine. There can be some weight gain. It's usually not nearly as profound as the others. Because of the D2 antagonism, it might have an effect at the insulin receptor, same as the others, but I think the incidence overall of increased blood sugars and such are less with lurasidone than some of it's the other ones. It has an approved use in depression and bipolar disorder. And when you look at the bipolar 2 condition, bipolar 2s tend to be different than ones which have regular cyclic such. The individuals with bipolar 2 often spend greater than 50% of their time in life with either depression or subsyndromal depression, really being on the low side. And it can be a difficult condition to treat. So in that regard, I think lurasidone is certainly an appropriate choice to see if you can manage the depressed side of things with the medication. And if not, it may help prevent cycling should an antidepressant be added to the treatment regimen. And it's okay to take with other medications. There's not a lot of direct interactions that either pharmacokinetic or pharmacodynamic, which is sort of like building up the straw that broke the camel back. If a lot of medicines have the same effect, like an anticholinergic effect, one alone isn't a big deal, but 3 of them with the same thing causes you not to be able to have a bowel movement. This is not one of those medicines that might have those effects. Question came in about the long-term use of Suboxone in terms of side effects. Suboxone, if tolerated, if you don't sleep 3 days with the first dose and can stick with it, and if not anxious or too nauseous with it, not anxious, but too nauseous and throwing up, which are some of the immediate side effects. The single most important long-term side effect of Suboxone is constipation. So the opiate receptor, the opioid agonists, any of them, any pain medicine can slow the bowel down, the colon down, and it can result actually in a bowel obstruction, a small bowel obstruction sits between the stomach and the large intestine. And it's sometimes very important to address constipation in patients who are using Suboxone. I think that would be the most important thing to watch for. I know I've had at least one presentation to the emergency room with small bowel obstruction. We had a patient with use. I mean, it was life-saving for him, the medication. And after we presented to the hospital, we figured out how to keep the pipes flowing, because it's really important. I have a question about advice for folks out there who have loved ones that refuse medications due to side effects. I mean, that's a tough one, right? And it's something that we all deal with. Sometimes it's trying different compounds. Sometimes it's just managing the side effects in a way. I think the most important thing in giving medications is for the physician, for the provider, to develop a cooperative relationship with the patient, whereby treatment is sort of negotiated, but negotiated to an endpoint that both people agree on, right? So ideally, your loved one will see a need for treatment. A lot of times folks don't, because of their illnesses, necessarily see the need for treatment. That makes it really hard. Sometimes the long-acting injections don't seem to have quite the same side effect burden. I don't think they necessarily affect appetite as much as some of the oral medicines do. You don't see the same side effects associated with serum peak. You take a pill, it's anywhere from 1 to 4 hours to hit peak absorption when the serum level is at its highest, and there's side effects associated with that. Sometimes the long-acting injectable medications, much smoother, even delivery of medications, you don't see some of those side effects associated with serum peaks and such. And so it really becomes a negotiation. And I've been trying to treat someone in the city who will only take the long-acting Invega shot, and she has an HMO, the insurance company, that we have to go. There's a specialty pharmacy in Florida. We have to beg, and it's been such a miserable experience. You're trying to get a refill, and they say, okay, well, you have to approve it. I call, sure, ship it. And then oh no, the family has to give us. Okay, call the family. And they stall so long until the prior authorization wears off, and then they say you got to get a new prior authorization. It's first time we did it was 6 weeks before we got the med. The second time it was about 3 weeks delayed, and the patient was about to go back to the hospital when it arrived. So hopefully do it. But if you can get folks on an injectable, sometimes that is a way to work around the side effects. And a lot of patients just don't like to have to take medications. They don't, they associate the medications with illness. They don't want to be ill, right? So it really becomes a negotiation. Now, on the flip side of that, if it's really important and the person is at risk for rehospitalization or at risk for harm in any way through neglect or impulsivity and such, the flip side is the courts, right? And one can get outpatient orders for treatment and such, not just commitment to hospitals. You can go and get an assisted outpatient treatment order and such. So there are legal ways of doing that. And I expect, and Nathaniel, Richard, you can correct me either through the chat or jump on, that NAMI probably has resources regarding the law and regarding legal means by which to pursue that. Is that correct, Nathaniel? You're muted.
You know, I'm no longer muted. I'm unmuted. Yes, NAMI as a national organization does have such resources. The best, most far-reaching, most comprehensive resources are available at the national level in DC, also through NAMI Illinois. At the local level, our resource line, our warm line, can be a good resource to people if they need information on who can help them with specific things.
Great, thank you. I thought so. See, you guys are great, right?
Well, our problem is we know we're great.
Yeah.
Right.
You know, let everyone
I'll
else
step off now.
Okay, thank you. Appreciate that. I have a question about Vraylar. What is a safe time period to taper off Vraylar? Vraylar is an interesting medicine, cariprazine. It has a little bit of a unique mechanism of action, useful not only in schizophrenic disorders, but also bipolar disorders. It really can function very nicely as a mood stabilizer. And the person who asked the question mentions that they started sort of at 6 for a long time, and there've been no mood swings for a year and a half, right? Things are going well. They're got it down to about 1.5. Is it safe to go off? So really depends on the condition. Most schizophrenia and related conditions tend to have a more chronic nature to it, that if untreated, symptoms will be present. Bipolar disorder, if it is a bipolar disorder, historically, I mean, the long course of the illness, it's a recurring and remitting illness, that there are periods, long periods of stability by which one may not have active symptoms of either high or low. And when you go back to the original Emil Kreplin's work, he's the first guy that split out the thought disorders from mood disorders and such. And people can go a long period of time without medication, right? The problem is that one doesn't know if another episode is going to occur. And I think one of the questions is making a correct diagnosis. You know, what is it? What was prior treatments for? The person who asked the question notes that you know, she's consulted with certain practitioners and some doubt whether it's a bipolar disorder or not. I just think it's important to get a good handle what the condition actually is and understand the risks. What are the risks? What are the benefits? Some people are willing to take more risk and some aren't. And I have a patient who had one episode of depression, and by golly, he is not going to go back to that place no matter what. And even though it's probably been 15 years, he insists on remaining on a maintenance dose of medication, which causes no side effects for him, and he's okay with it. You know, he doesn't want to go off, right? Some people really would like to not be on medicine. And it's just a discussion on understanding what the risks are. What are the risks of a recurrence? What's the risk of another episode? How to recognize it? Should it occur? Sorry, my top lights go out. These things shining in front of me. So what are the risks of it occurring? How to recognize an episode should it start up. A lot of people don't necessarily recognize when they're starting to become symptomatic, so it's often useful to develop relationships with the family, with loved ones, so that others can recognize it and reinstitute treatment. I think these are the important discussions to have. I mean, there's no right answer to stay on or go off. It's a risk-benefit analysis. Let's see, about 16 minutes ago, I got the message that we have about 20 more minutes. There are a lot of questions in the chat. I mean, how do you monitor patients for med compliance? I mean, if it's medicine, you have blood levels on. I mean, I have people bring me their bottles and I open them up. I count bills, right? That's one of the ways. I watch and see how often patients are refilling their meds. It's a good way to tell. Does drinking alcohol really affect psych meds? You know, people, there can be synergistic effects. One can get, you know, more drunk on meds. Some people notice that on meds, they don't just get tired on alcohol and such. I think the party line is you don't drink if you're on medicine, at least not a lot. If you're with family at a wedding, you have a glass of champagne, you know, but if you're pounding a 12-pack on weekends, it's not a good idea. Question about traumatic brain injury with bipolar and schizoaffective disorders. Does it make it harder to treat? Is traumatic brain injury a red flag to someone trying to get accepted into permanent supportive housing? To answer the last part, it shouldn't be. All right, TBI, it can appear in a number of different ways. And whether it's difficulty with memory, whether it is sort of affective dysregulation and such. I mean, whatever it is, it's treatable. It shouldn't necessarily be a barrier to supportive housing. This TBI and the combination of an underlying major psychiatric illness, either bipolar disorder, schizoaffective disorders, make it harder to treat. There's no real data about that. I think we treat what we see. And what I do if there's been a traumatic brain injury, I'll often add back a lot of the sort of non-pharmaceutical nutrients, you know, a little magnesium, things that will help diminish sort of the effects of neuroinflammation, whether it's magnesium, which sort of blocks the endpoint of the inflammatory cascade, or methylfolate, you know, B vitamins and such, other sort of antioxidants, krill oil, omega-3 fatty acids, fish or krill oil, things like that, just as a means of optimizing the environment as much as possible. Well, how much magnesium? Okay, so my colleague Alexander Mauskopf, who runs the headache clinic in Manhattan, who is like a savant with magnesium, he uses it for migraine, and he tells us that the magnesium dose is about 400 milligrams, either once or twice a day. And the best magnesium compound is magnesium glycinate. So you can see oxide, gluconate, citrate at the pharmacy, but magnesium glycinate, Glycinate. It's a very useful compound. Best form of magnesium. And then I'm going to look for a slide, if I may, real quick. Stress begets inflammation. Inflammation changes the way the central nervous system takes in nutrients to produce serotonin and other neurotransmitters, turns it into inflammatory cytokines. It goes to the microglia. Microglia will then release glutamate. Glutamate is excitatory. It goes to the cell. Glutamate opens up at the NMDA receptor. So ketamine blocks NMDA receptors here. But glutamate opens them up. So people under stress who have a high intensity and will have these open channels, okay? These NMDA receptor opens up calcium channels. Calcium goes into the cell and eventually weakens the cell to the point where it becomes dysfunctional and over many years will die off in the process called apoptosis. Magnesium actually occupies that channel right there and keeps calcium from going into the cell. So in that regard, magnesium is neuroprotective to people who kind of have this chronic stress condition to help block the effects of this inflammatory sort of cascade. So I just wanted to share that with you because it's a really cool slide and very colorful, and the science is actually fascinating to me. So magnesium glycinate, 400 milligrams to start with, maybe up to twice a day. If you have migraine, all the better.
Thanks for a great presentation and for answering all these questions. This event, it's an annual event, the annual meeting. We always try to feature a leader in mental health and psychiatry, and the Q&A part is so helpful to people because oftentimes, as you know, they have very personal experiences and questions that they want answers. So thank you.
You bet.
Thank you, Dr. Shulman. We really appreciate your coming on for us.
It's a pleasure, and my best regards to some old friends that I saw in your attendee group this evening. After my 20 years on the North Shore, it's a special place in my heart as well. Thank you.
Great. Well, thanks again so much.